we'll move on to Annanya now. Annanya is representing Abbott. She's the Chief Connectivity and Solutions Manager, the Asia Pacific region for Abbott. Annanya, are you there?
Yes, I'm here. Can I share my screen, Asha?
Yes, please. Yes. Let me just unpin my video. There you go. Yes. Can you see the button? Yes. Wonderful. Okay, bilkul sahi hai.
Can you see my screen?
I can see your screen. Yes.
Perfect. Okay. Let me put this in slideshow. There you go. Okay. So very good evening to everyone who's tuned in. And thank you, Aisha, for the kind introduction. So I'm really humbled to be part of the session today. And Hatem and Wasif have pointed out, this is really an opportune time to talk about digital solutions in the realm of infectious diseases, because we've seen how COVID-19 has really catapulted the adoption of digital solutions, to be able to effectively contain the spread of the disease. Right. So over the next few slides, what I'm going to show you is how, I think that rapid point of care testing can be linked with data, right, in the whole space of hepatitis C elimination. Okay, how can that be an effective tool? So with that, I have my team here from Abbott, and we're very happy to be supporting Pakistan's first national hepatitis C hackathon. So we have Priyank, our Director of Medical Affairs, Dr. Mohan, as well as Saad Bhai, who's our country manager for Pakistan. So with that, I'll get started. Just to take a step back and understand what really is hepatitis C. And so we've touched upon it, and it's really the liver. It's a liver disease that is caused by the blood-borne hepatitis C virus, so HCV for short. And on a very basic level, to contact the disease, you would need to be exposed to a person's blood that carries this virus, right? So which is why it's a blood-borne virus, which gets transferred when you come in contact with a person who has the infection. So common modes of transmission would be effectively intravenous drug use. So we call them people who use injectable drugs, PWID for short. So this can be either people who are on substance abuse or who are taking therapeutic injections. So this is paradoxical. So you could be admitted in a hospital undergoing a treatment where you need to have treatment given through an IV or therapeutic injections, and you could be at risk if the hospital is not following safe injection practices. Okay. Also, like Vatif sir has pointed out, that this could be through transfusion of unscreened blood. So if I have a genetic blood disorder where I need to have frequent transfusions, but if the blood of the donor is not screened, I'm again at risk of contracting the infection. And then, of course, sexual practices that lead to exposure to blood. And this is the highest population here, are the transgenders and, male to male sex. So if we now move to the left-hand side, just to talk about the progression of the disease, it's a curious disease because you get infected, but you don't even know that you have the infection, which is why we call hepatitis C the silent killer, because by the time you are aware of the infection, you've already sort of entered the chronic phase of the disease. And this happens in 80% of people who get the infection because it is asymptomatic. Right, so it's very difficult to tell that you're sick. By the time you reach the hospital, you're in a chronic stage where it becomes a persistent infection, difficult to treat. And then, of course, from there, about 30% of people go on to have severe liver damage and cirrhosis. And then from that, about 4 to 5% of people get liver cancer and end-stage liver disease. And then 6% of people actually die from the disease. Okay, so this entire progression cycle is accelerated by immune compromised diseases such as HIV, tuberculosis, or from excessive consumption of alcohol, or if you have a fatty liver condition. Now, what's interesting is like Aisha pointed out, that we do have a cure for the disease. Okay, so we have direct acting antivirals. So these are drugs that target, the multiplication process of the virus. So you're blocking that and thereby controlling the spread of the disease. And it has phenomenal cure rates of 95%, right? And so here's here's the contradiction, that you have the disease, you have a cure, but still this steady infection rate. Okay, so why is that happening? And disproportionately so in low and middle income countries. And this is primarily due to lack of access to diagnosis and treatment early on, right? So we need to be screening a lot more people, right, to be able to catch this disease at the acute phase and then treat and cure it. Okay, and then of course, to compound that problem, we do not have an effective vaccine against hepatitis C. Like we do have one for hepatitis B, but there is no effective vaccine against hepatitis C. Okay, so it is a global problem. And to put a scale to that, this is 71 million people who are estimated to be living with chronic hepatitis C. Okay, so that's the 80% that I spoke of. And then the 20% of people who do get diagnosed at an early stage, we have only about 8% of people getting treated. Right? So you have fallout rates not just at the stage of diagnosis, but also at the stage of treatment. And then, to add to that, like I've said, HIV co-infection and people who use injectable drugs are at high risk. So that number's 2 to 6 million people. And the reason I'm highlighting that here is because these are the high-risk individuals that we need to be reaching out to, but somehow they are left out of our national response programs. Okay, so we really need to, the essence is we need to target the vulnerable population, the hard to reach population, the population who do not, come forward to take treatment because of the fear of stigma. So we need to reach those people to really drive down, that mortality rate. We have 400,000 people dying of this disease every year. So in 2019, we had 1.5 million new infections, right? And Pakistan has the second highest burden with almost 10% of that global number, which is over about 10 million people, 1 in every 20 people getting infected. Okay. So like, again, like Watip sir pointed out, WHO set down, so in 2016, when, this was a neglected disease really till 2016, at the World Health Organization Assembly, when these numbers came out in terms of the death toll of hepatitis C, which was 1.4 million deaths from hepatitis B and C combined, which is what we call viral hepatitis. This was higher than the numbers that we had for HIV and comparable to TB, which is when the decision makers sat down and said, we need to come up with an elimination strategy. Okay, so I've now zoomed in just specifically into hepatitis C. And like I've said, there is a glaring testing and treatment gap, right? So like I've said, only 20% of people are getting diagnosed. So we need that number to go up to 90%. And then we need almost 80% of those people who get diagnosed treated, right? So we need to go from 8% to 80%, okay, to be able to then reduce incidence by 90%. And reduce mortality by 65%. Okay, so that's the sweet spot that we need to be at to reach that target 2030. Okay, now coming to what is coming in the way of getting to that target. Okay, so what I've really highlighted here on these 6 boxes are, lack of awareness, starting with lack of awareness. And like I've said, it's difficult to know that you have the disease, right? So, and because this can be, spread through, contact of blood of an infected individual, I can get this if I, if I go to the barber for a shave and I haven't made sure that he's used a disposable blade, or I can get this if I go to a tattoo parlor, or if I get pierced, right? So, there could be multiple ways in which this can be spread, and I would not be aware of that, right? So let's say as a parent of a child who probably needs blood transfusions, I need to be aware that I need to ask the doctor, hey, has this blood been screened, right? So there is lack of awareness. And here, we need social media to intervene. We've seen that with COVID-19, how social media has played such a huge role in increasing the general population's awareness about the disease. Now, this needs to happen across infectious diseases, right? And hepatitis C, as well. So I think that building awareness among our communities, and like I've said, also getting care to the people who are most impacted by this disease, right? Without stigma, right? So these can be people who are, drug abuse, HIV co-infections. We need to treat them, right? Then we have siloed health programs. So now we understand that HIV co-infections is a huge reason to get HCV, right? So what do? We need to have integrated health programs. What does that mean? So we have Unit 8 and we have partnering with Find to really include HCV testing and treatment into their HIV programs. That's how we need to be thinking about healthcare. It has to be, universal, health coverage. It has to be integrated, right? So we're getting maximum benefit. We're pooled financing, right? That's what we need to be looking at. Then we have, if we move over to the left, poor awareness and limited funding. And now this is really hinting at competing health priorities, right? For the lack of a better word, we've seen COVID-19 really being prioritized in the last 2 years. We've had HCV diagnosis and treatment services, 60% of the treatment and diagnosis services being disrupted because of COVID-19. Right. And then, of course, we have limited funding. So we do know, like, Wasif sir pointed out, we might need about, 1 billion or over, about 8 billion to be able to manage HCV, to be able to reach that target 2030. Now, what does that mean? That at status quo, where Pakistan is about in 2018, there's about 600 million that has gone into HCV management. Right? So this needs to go up by 2x to be able to support and reach that target 2030. Okay. And when we say, investment, it has to be a sustained investment over the years to reach that elimination goal. Okay. So we do need, the global funds of the world, the Bill and Melinda Gates Foundations of the world, corporates, everyone coming together in a public-private partnership to make this happen. Right. And then in my mind, it really hinges on these two pieces where, like I said, I want to be able to have a rapid diagnostic testing modality. What does that mean is that I don't have to walk 100 miles to a clinic, like Asha pointed out, these are people in villages, that might not have access to healthcare. How do I bring the test to them rather than have them go to a centralized facility? This needs to be, something as easy as a pregnancy strip test. And that's what we're thinking when we say easy and rapid. And then, of course, I need to have data which is essentially allowing healthcare, policymakers, NGOs, the ministries of health to really see, is my hepatitis C program working efficiently? Am I reaching the right population? Are they getting tested? Are they getting treated? Okay, so now we come to rapid point of care testing. Okay, in this whole picture that we've spoken about, it's an important piece of that puzzle because, like I've said, conventionally how this is happening is that we have, a method of drawing the blood from the patient. This could be, drawing blood from the vein or drawing, blood from a finger prick. And then you have to do two tests. Okay, so one which is you're detecting for the antibody against the virus. Okay, so now generally when a person gets infected by a virus, they would mount an immune response, which is what we refer to as the antibody. And so the first step is you're detecting the antibody in the blood of a person who's been exposed. But then that doesn't tell me is that, did that person have a past infection? Is the person currently infectious, has a viral load that can cause transmission, or whether it's a false positive. So then I have to do a confirmatory test, which is now you're detecting for the virus, the genetic material of the virus in the individual to make sure that the person is currently infectious and can transmit. Okay, now this entire cycle is, can take about 1 to 4 weeks, until diagnosis. And at every step, you might lose the patient to follow up. Now you have, in the gold standard where you have the venous blood draw, you have the person coming in once, then have to come in, again for a blood draw. You can have this person not come back. Okay, so again, like I said, the idea is I want to have a simple, easy to use rapid test that I can bring into the hands of the care seeker. Okay, so like I said, this should be as simple to use as a pregnancy strip test. Right? This could be either detecting the antibody, it could be detecting for the RNA, but I don't want to have to use special equipment, trained professional. I want to be able to do this at home. And we've seen that happen with COVID-19. We've had rapid self-test, which is essentially for end users, because we know that our healthcare systems are too overburdened, right? So improve access, shorten time to results, because I don't want to be infecting 10 other people while I wait for my diagnosis. And I need this to be cost effective. Now, we do have rapid tests in the market, which are under $1. Right? So that's what we need. We need innovative testing strategies. And then when you combine that with technical solutions, right, that's really the magic bullet to achieve that 2030 goal. And now coming into what could those technologies really look like? What do we need it to do? Okay, so that's where we talk about digital diagnostic data connectivity. So what do I mean by that? I need the right data, which is my diagnostic data, potentially with symptoms, my background, comorbidity, so that I can identify where these Venn diagrams overlap. And I need that information in the right form to reach the right person, okay, which is my healthcare provider, my ministries of health. I need them to see this, and at the right time. I need this to happen at a real-time basis, right? And just like how we're doing for COVID-19, we get daily updates, how many new infections, how many people dying, so that we know what we need to do to stop the spread, right? So, and I've put, depicted a smartphone here because we've really seen the smartphone adoption really explode in the last few years. Okay, now this is in low and middle income countries as well. And it is really, the features, I think we all can agree, it really has the computational power of literally being used as a medical device. Okay, so it can do contact tracing, and we've seen that for COVID-19. You can use it for, to pull out data from a sensor that you have put on your arm for, let's say, to monitor your glucose levels. So just the use cases are just, varied. So I really want, like I've said, I want to improve the patient experience, which means I want to bring the test to the hands of the consumer, which is what I refer to as better care, better health. So I want my population to be tested, to be screened, and then that information in real time to feed into the right channels. Okay, so improve population health and then better value just by virtue of getting this into the hands of the right people. So if I have a community healthcare setup, let's say in a district in the Punjab province, they can act on this at real time and give care to the person who's seeking it. Okay, and then I can escalate it up that food chain to the national, public authorities. So let's say I want the Ministry of Health in Pakistan, or I want the Punjab province specifically to see how their elimination program is working. That information needs to escalate. And then, of course, the global, policymakers, this is your WHO, these are your funders, who need to see, is this elimination target that we've put, is this blueprint actually working? So to monitor, evaluate, re-strategize if needed, okay? So better value by decreasing per capita cost, which means that if I detect that the disease early and treat it, I can prevent that patient from going into a stage of liver cirrhosis or cancer, which is a far more, has health economic impact than treating that person early on, okay? Now, this is the overarching theme. Okay, so this is really what this talk is about in terms of I want to test, I want to trace, and then I want to treat and track this patient along the entire care continuum, okay, which is what is referred to really as the public health approach. And this is across infectious diseases. Like I've said, it's not limited to HCV. We've seen this happen with COVID-19. We need to do this for diseases in general before they become a pandemic. Okay, so we need data reporting happening early on. We need to train, let's say we have a community worker, we need to train them to be able to use these digital tools to then relay that information in real time, okay? And information as in information that will help me contain the disease in a timely manner. I need to isolate geospatial information. I need to understand which province, which district, do I need to mobilize my resources, and which is what we refer to as precision public health, because now you have a targeted sort of approach, and obviously the results would be better, right, from having a focused sort of action plan. So now I want to bring back the entire cascade of care that we spoke of, okay, and then how digital diagnostic data really fits into that entire, it actually addresses a lot of the problems along the entire chain, okay, of care, where we see, for instance, let me put my laser pointer, sorry, here, okay, so now we have, digital solution which can be employed at the point of the rapid testing modality. Okay, so I implement this, and then that has ripple effects in that I can see the immediate value of capturing data at that, at the start line, and then that will help me accentuate which are the disease hotspots. Okay, have I optimally deployed resources there? Okay, am I being able to understand that my patients are being put on the right curative course, and then are they sticking to that treatment so that I get a good program efficacy outcome? So data is really that starting point to be able to get to that final stage where you're saying, okay, this is working. Right now, over the next 3 slides, I really want to talk about how you can deploy this at the level of point of care testing, disease hotspot identification, and treatment adherence. Okay, so this is just an example of a nurse and a physician at a community health center going and testing a person in their home. Okay, so what does the nurse need? The nurse needs a point of care testing that is easy to perform. I do a finger prick, and then I have lines on a test. Let's say 2 lines that tell me it's a positive test, 1 line that says it's negative. I need this to be that simple. Okay, and then I need to gather that data. Historically, how this is being done is that the physician has to actually write this down in a piece of paper. And so that could lead to loss of data. I need to, let's say, carry 5,000 sheets of paper then to my national center, and then have to type this and key this in. This process can be really harrowing for someone to do. So I need to introduce a system which is again at the point of care of testing, where I capture that information and it gets relayed in real time to public health authorities. Okay, so that brings us to the second piece, which is now, let's say in real time, that information has gone to the public health authorities, right? For them to understand, like I said, is my program effective? Now we know that Prime Minister Imran Khan in 2019 laid down his idea of what that elimination plan needs to look like, right? So he said from 2020 to 2026, I need the population 17 years or older getting tested, treated, and cured. Okay, so this is about 90 million people. And then from 2026 to 2030, I want the rest of the eligible population 12 and above to get tested, treated, and cured. And by the beginning of 2022, I want 500,000 people treated, and I want to bring that incidence level down to 20%. Now that's an ambitious goal, but how do I know that I'm hitting those numbers if I don't have a way of visualizing a dashboard that tells me that, right? So I need to understand, am I targeting the right population, the right age group, right? Am I reaching that, the right, sort of treatment outcome? Am I targeting the right sites, the right provinces? Like all of this information, I need to be able to see this to know that it's working. Okay, I need global funders to know that the money that they're funding is going into good use, is having an impact. Okay.
Yeah,
then that last piece.
A little over time. We'll have to.
Yeah, just wrapping up. So just.
Sure.
Sorry, Asha. Yeah, so just the final 2, I think about 1 slide or so after this, where I really want to drive home. And then, of course, like I said, that end piece where you have treatment. And this is a digital medicine program that could be used across diseases, right? Where you have a patch that is worn, like a sensor patch that is worn externally on the stomach of the patient. And then they take the medicine, which has an ingestible sensor on it. So that sensor, when you consume it, sends a signal to the patch. That information is then transferred to an app, and then it reaches the healthcare provider who knows that their patient is sticking to treatment, right? So the final 2 slides are really about, if there's anything that I should leave you with, is really the 4 T's, which is test, trace, treat, and track, right? So like I've said, get the drugs to the right people. We have seen Pakistan doing really well in that you're providing these drugs and treatments for free. We need to continue doing that. And of course, empower our communities to be able to do micro elimination programs. Okay, so then that final slide is really the 4 T's, the test, trace, track, and treat, and then decentralize, democratize, and digitize healthcare, which means that I want to get tests to everybody, leave no one behind in terms of decentralize and democratize, and then digitize, which means I should be able to see disease burden, patient care attention, drug-resistant health outcomes, anything I need to see on a real-time basis. So that's what I want to leave you with, and thank you so much for your attention. I know I'm a bit over time, But thank you. And I'm looking forward to the great sort of ideas that are going to come from the participants as well, right? So thank you. Asha, back to you.